Today we're going to review the use of POCUS in the evaluation of a retropharyngeal abscess. So first let's review some indications that may prompt you to evaluate for an RPA. As you probably know, RPAs are most common in children less than 4 years old, and most often will present with one of the following symptoms that you can see here listed on this page. So the child is often ill-appearing, they may have drooling, they may have a report of difficulty swallowing or a change in voice, classically a muffled voice. They may have stridor or present with some degree of neck stiffness, swelling, a mass, or lymphadenopathy that you can see on exam, or torticollis reported by the parent. Any of these symptoms that you see, you should consider the diagnosis in the appropriate population. So let's now talk about the basics when it comes to where to put the probe and probe selection in the evaluation of an RPA. So we use what's called the transcutaneous approach when evaluating for an RPA, and you want to use the linear probe. You can see in this image that the probe is placed under the angle of the mandible with the probe marker pointing toward the ipsilateral ear that's on the same side. And we're going to discuss this technique in more details in the coming slides. So let's talk a little more about the technique. So if possible, the patient should be positioned sitting at about a 45-degree angle. Now, given that we mentioned the most common age for RPA is less than 4, sometimes this can be difficult to accomplish having the toddler sit on their own. So remember, utilizing the parent to help is most useful. So have the baby or toddler sit in the parent's lap, and you can often obtain the angle for optimal visualization using this technique. So next, as we mentioned, you place the probe marker under the angle of the mandible, as you see in this picture. It's pointing towards that ear on that side. The probe marker itself should be at about a 90-degree angle to the neck, and the depth of the ultrasound machine should be set to about 5 to 6 centimeters, depending on the age of the patient and the degree of overlying adenopathy. So remember, if you have a significant amount of adenopathy, you're really going to need to increase your depth, and vice versa. Okay, next let's look at some normal anatomy before we get into looking at the abnormal anatomy. So as with a lot of techniques, this one is similar, that you really need to be able to orient yourself to what you're looking at to be able to find what's abnormal. And this can sometimes take a little getting used to in these views. So most helpful is first identifying the carotid artery. This can really serve as a great landmark to help you note that you're in the right area to start looking. So identifying the carotid artery using color Doppler can be helpful. And then you want to look deep to this vessel until you identify the vertebral body. And remember that, vertebral body is bone, so it's dense and it should have shadow artifact that you see. Once you've identified the vertebral body, you should fan cephalad to caudad in this area to fully examine for any fluid collection or inflammation. And as you can see in this normal picture, you have the carotid, the vertebral body, and you see everything's fairly collapsed. The carotid sits quite close to the vertebral body, and you don't see anything that looks like cellulitis or inflammation. You can often, I will mention, see the jugular vein, although I usually tell people to look for the carotid because it's easier to identify, as sometimes if you're pressing too hard, you can collapse the vein. So here's just another still picture looking at that similar landmark, the vertebral body and the carotid artery. Make sure that you put color Doppler on to help you identify these landmarks. So next, there's a few techniques that you need to use to fully evaluate the area for any inflammation when you're looking. So first, you evaluate for your landmarks. Once you find your landmarks, here's the vertebral body that you see. I'm going to erase this so it's out of your way. And you're looking in front of the vertebral body. You don't see that flush collapsed area. Now this person is doing what's called rocking. They're moving the probe medially to laterally while examining this entire area. And you can see that they're seeing this large collection in that area. We're going to look at some more pictures and we're going to look at a lot of abnormals, but make sure that you're rocking the probe medially to laterally to look in this area. Next thing you're going to do is slide in the area. So similarly, first you want to find your landmarks again. You want to locate the vertebral body. First, I always tell people, because it's one of the easiest things to find, along with the carotid. And then you want to move the probe cephalad to caudad to fully examine for any fluid collection. And remember that when you're doing this, you're sliding the probe, and then you also need to fan in that area so as to fully evaluate for inflammation or a miscollection. So you can see here the vertebral body, and in front of it you see not a normal collapsed flush tissue, but you see what looks like inflammation and collection, which we're going to look at next. So let's now look at some abnormal POCUS scans of an RPA. So this POCUS here shows a mixed hypoechoic collection that you can see here with very kind of ill-defined borders anterior to the vertebral body. It's important to remember that collections, specifically in RPAs, will often appear with these irregular borders. Inflammation in general for an RPA is similar to inflammation that you see in other parts of the body. So remember to look for thickening of the tissue layer and loss of these normal tissue appearances. The same principles apply for both. And also that these fluid collections usually always appear anterior to the vertebral body in an RPA. Other things that you can use in the evaluation is color Doppler specifically can help you in the differentiation of an enlarged lymph node versus a fluid collection. And that enlarged lymph nodes will have normal vascular flow at the central hilum, whereas a fluid collection, will not. Lymph nodes also, remember, appear homogeneous and circumscribed, whereas an abscess will also have that more irregular shape that we mentioned before and be hypoechoic or anechoic in nature. It's also important to keep in mind, and I like to mention that in the beginning stages of this, visualization of normal structures can be difficult. So it's really recommended that you compare the findings on the contralateral side. And always remember that the normal prevertebral space lacks any tissue thickening, and the vertebral body is seen close in approximation to the carotid artery and jugular vein, whereas here you don't see that. Look at a few other abnormalities. So this POCUS here shows a hypoechoic fluid collection with poorly defined borders, although a little bit more defined than the one previously, which is concerning for an abscess, and a fluid collection was seen on CT scan of this patient. Here's another one that you can see. This POCUS shows a more isoechoic collection with a hypoechoic rim that you can see again anterior to the vertebral body. And again, remember that you're not seeing that flushness of proximity of the carotid artery to the vertebral body, so this is abnormal. Here's another one. This POCUS shows a less common finding with a circular heterogeneous collection with an effaced IJ that you can see up here. Although less common, effacement of the vessels can be seen with significant inflammation. So again, here's this abnormality that you see anterior to the vertebral body and the carotid artery. So now that we've evaluated a number of normal and abnormal POCUS scans in the evaluation of an RPA, let's just review some pearls and pitfalls. So first, just remember to always identify the carotid and vertebral body first, as these can really hone you in to make sure you're looking at the correct anatomical area for evaluation of the RPA. You then want to look for any hypoechoic or anechoic collections in this prevertebral space, and evaluate for any poorly defined borders, because remember, RPAs often have these poorly defined borders. In regards to pitfalls, make sure that you're not duped by lymph nodes that you think are an RPA, and remember that applying color Doppler can help you in differentiating this. You want to avoid too much pressure, as that can compress structures and you may miss things. And remember that POCUS in the evaluation of an RPA is an advanced POCUS technique, so comparing the normal and abnormal side can often be helpful in this evaluation. And finally, remember that there is limited literature and studies at this time in the evaluation of POCUS for the RPA. So although presence of a suspected RPA and POCUS can be helpful in the management of your patient, it should not replace the current evaluation and diagnostic methods for an RPA. Let's now review a case of a patient that I saw in the ED. So this was a 3-year-old who presented with 2 days of fever, fussiness, and neck stiffness. The parent also reported he had had 3 days of cough and congestion, some decreased PO over the past 2 days, but today was refusing to eat or drink. physical exam of this patient, their presenting vital signs was a temp of 39. They were tachy to 145, had a respiratory rate of 30, and a pulse ox of 100% on room air. Pertinent physical exam findings: the patient was crying on exam. They were very fussy, sitting in their parent's lap, and really refusing to move their neck or their head. So the differential of this patient includes the following that you can see here. So meningitis, retropharyngeal abscess, epiglottitis, a PTA, uveitis, and tracheitis. In this particular patient, due to his presenting symptoms, we performed a POCUS that you can see here. And here you see the vertebral body, and anterior to it, you see this mixed echogenicity collection that was concerning for an RPA. So this POCUS really expedited the ordering of a CT scan and ENT consultation. Labs were done. The patient had a white blood cell count of 33, an ESR of 62, and a CRP of 5. The CT scan confirmed the findings of an RPA, and the patient was taken to the OR where a 1 centimeter by 2 centimeter area of swelling in the left retropharyngeal area was evacuated of pus. The patient was admitted post-op and discharged home 1 day later on Augmentin. In summary, using POCUS in the evaluation of RPAs can be high yield and a quick exam to perform. It is important to remember that this is considered an advanced technique and it may be challenging for beginners, so lots of practice is really key to success. Remember to always locate the key landmarks first, including the vertebral body and the carotid artery. This will help ensure you're evaluating the right space. Compare the normal and abnormal sides to help aid in the diagnosis. And always order confirmatory imaging. Remember that this technique can take some time to get used to. I hope you try it in your next patient when you have a suspicion for an RPA. Good luck and happy scanning.